You're listening to Frontier Matters, the podcast from 1914 Reader. Join us as we dive into bold conversations on growth and change in the frontier economies of the world.
Our guest today is a public health leader who helped shape Nigeria's COVID-19 response while serving at the Nigeria Center for Disease Control, and then supported global vaccine equity efforts through COVAX. She now leads country and regional engagement for Lassa fever vaccine development at CEPI and is based in the UK. Alongside this, she's completing a PhD at the London School of Hygiene and Tropical Medicine, focused on the feasibility of Nigeria's vaccine manufacturing strategy with comparative lessons from India and Thailand. Has recently authored a paper examining Nigeria's post-COVID manufacturing ambitions and their regional implications. She's also a senior fellow with the Aspen Institute's New Voices program and co-convenes the Public Health Incubation Hub, a network of nearly 1,000 young public health professionals in Nigeria, where she mentors emerging leaders. Beyond policy work, she has written widely on epidemic preparedness and Lassa fever, including an op-ed on fast-tracking a Lassa vaccine. Oyeronke Oyebanji, welcome to Frontier Matters.
Thank you very much, Faye. It's a real pleasure to be here. And I'm smiling because I've never heard someone describe me with all these words. So thank you very much for the time.
Yeah, okay, because I was to soften you up to give us the really good answers you're looking for. Okay, I think my first question will be around a broad recollection or reminiscence, if you like, from you. You are the front line of Nigeria's COVID response when you worked at the Nigeria Center for Disease Control, NCDC. What is the lesson or abiding memory that has stayed with you the most from that experience?
It's a very interesting first question because I've actually never talked publicly I've never talked publicly about my experience with the COVID-19 response. Of course, I've had several chats, but this is probably the first time where I'm voicing out some of it. So at the time in January 2020, I had just left my job at the Nigeria Center for Disease Control to move to the UK and to move to a new job. And when I left, there were a few cases of this new virus in China, and scientists were trying to understand how the virus is transmitted and who is vulnerable and what's going to happen. And even though I work in public health, it never crossed my mind at the time that we were dealing with a potential pandemic. It was just for me, another virus, another set of cases in a country very far away from us. And so I moved to the UK and started a new job. I didn't realize what was going to come a couple of months after. So I guess the first thing I'm trying to say is by the time I started supporting Nigeria's COVID-19 response, I was loaned back from my current organization to my previous organization. So I had just jumped ship, but we realized that this was a huge pandemic evolving and there was support needed. So I was one leg in the Nigeria Center for Disease Control and one leg out. Again, very hard to voice out what that period was. But all I remember was things moving rapidly, things moving at incredible speed, and living with a lot of uncertainty. So some of the first steps were just looking through what's happening globally and what guidance do we need in Nigeria. I think we were very lucky at the time to have a strong Nigeria Center for Disease Control, to have a strong National Public Health Agency, because the basics were there. There were very smart people. There were strong systems, laboratory systems. There were people who could set things up. But we were dealing with a new virus. So it was a blend of how do we use what we know from known outbreaks, known diseases? How do we use the systems that we've built and combine that with the understanding of a new virus? So a lot of the time, the early days were spent thinking through what is the risk for Nigeria? What are the policies we need? What are the systems we need? If this virus spreads to Nigeria, what's going to happen? And of course, a few months after, by February, the first case was recorded. And I remember supporting some of the early communications work, some of the early press releases, some of the early materials used to not just announce cases, but to tell people what the virus was. There was also a lot of time spent by other people, not me, thinking about, okay, so now that the virus is in the country, how do we expand testing within the country? And my role was simply to support a lot of this thinking from a policy aspect. A lot of my time, again, was spent with leadership and making sure that they were well prepared and that things were moving from the technical side to the policy and decision-making side and vice versa. So I guess in a nutshell, my biggest memory or recollection from that period is just how quickly things moved, how lucky we were to have the foundation set, and how lucky we were to have a group of experts who were able to get things moving rapidly.
I want to move a bit away from COVID and talk about Lassa fever because we've done a lot of work in this. And Lassa fever has been in the news even before COVID. But given the landscape of infection and the concentration doesn't really affect people in Lagos and some other large urban centers, nobody really knows what it is. It's just, another story we see in the news. So, can you just walk us through a bit of what Lassa fever is, how it spreads, where it hits hardest in Nigeria, for example, the damage it does, and what is the current landscape for prevention and treatment?
Yeah, I'm going to crack a joke because my friends asked me why I was coming to this podcast, and I was like, oh, they want to talk to me about Lassa fever, and they thought it was strange because people don't want to talk about Lassa fever, right? And like you rightly said, Toby, maybe because it doesn't hit urban cities as much, and maybe because the people mostly affected are poor people, much less said about Lassa fever. Anyway, to your question, there's a very interesting history of Lassa fever. Do you know that the virus was first discovered in Nigeria, in a place in Borno State, actually called Lassa? So it is named after a town in Borno State. And it was discovered in 1969, so nearly 60 years ago. And another reason why the disease is so interesting is because even after 60 years, we don't have a vaccine for the disease. We don't have any approved therapeutics for the disease, so we don't have any approved drugs. The disease is managed through an antiviral that is not necessarily approved for Lassa fever but can be used. And we still know so very little about the disease. And I think it just points to, again, the fact that this is a neglected disease because the people who are affected are more poor people living in rural settings. So Lassa fever is a viral disease. It is what you would call a viral hemorrhagic fever. So it's almost similar to how you would describe Ebola virus disease, in the sense that when it gets really bad, people actually bleed from their nose, their ears, their mouth. But that's when it's at the worst stage. The other thing about Lassa fever is that the symptoms and the signs start like other febrile illnesses like malaria. So people get headaches, they get a fever, sometimes body pain. And maybe that's another reason why it's not as commonly diagnosed, because in Nigeria, as most listeners will probably relate to, when you have fever and headache, the first thing you do is you drink Panadol. If it doesn't go, you say, oh, I probably have malaria. Then you get anti-malarials. And then, 1 or 2 weeks after, you probably get better because, with the virus, you can actually get better if you don't get to a terrible stage. And so it is underdiagnosed because people don't test enough. We also don't have, we have some capabilities, and I don't know the accurate number of laboratories now in Nigeria, but we don't have a laboratory in every state that can test for the virus. You probably have about 10 to 15, I would guess, off the top of my head. It used to be 5 when I worked in Nigeria. But you don't have many centers in Nigeria where you can actually test for the virus. And so there is an estimate that there are 100 to 300,000 infections across the world every year, but it is an estimate because the testing capabilities vary. The virus is spread mostly by rats, mastomys rats. And so people get the disease when rats pee or poo on food and they eat them. And the best way to visualize this is if you travel, when I was younger, I would travel a lot from Lagos to Kwara or Lagos to Benue. And on the road, you would see people spread gari, I think as a way of storage or as some way of drying out food. But anyway, when people do that, rats go and pass excreta on the food. And then people pack them and eat the food. And that's how the virus is transmitted. The virus can also be transmitted from person to person. And that's why during Lassa fever outbreaks, you see health workers getting infected. Because a person shows up to a hospital, shows up with the signs and symptoms. Sometimes the health worker, without gloves, without the right precautions, without the right protection, starts to touch and check. And it is only after doing that that they might realize this could be Lassa fever. So sometimes the index of suspicion, what health workers think is this might just be another case and they don't think about infection. Of course, that is changing and there's higher sense of suspicion and you see health workers, protecting themselves better, especially post-COVID. But that's another way that Lassa fever spreads. So there's the rats to the human, but then there's also human to human, especially in healthcare worker settings. The disease is endemic in Nigeria, but also in Guinea, in Liberia, and in Sierra Leone. And what that means is that in those countries, you have the rats that carry the virus. And so, there are things you can do to prevent infection, but the rats are there. I mean, sometimes I hear people use words like deratization. That's a word I hear people use in Nigeria. Like, let's go catch all the rats and kill them. But it's just not possible to do that. So that's how the virus spreads. In Nigeria, most cases are in Edo, Ondo, Ebonyi states, and more recently in Bauchi state. But again, it always changes. I think the more you look, the more you see with the virus, right? Last year, there was a very high number of cases in Taraba State. Unfortunately, our research capabilities in the country are still not optimal. So when you see a spike in cases, people are not really asking why is there an increase in cases? Is it that we're looking more and we're seeing more? Or has something changed about the virus? Or has something changed about people's behaviors? Are people more exposed to the infection or whatever? I mean, it's very hard to say because there's not enough research happening in that aspect. So that is it. In terms of vaccines, like I said earlier, nearly 60 years since this virus was detected, still no vaccines. There is some work, and last year the first phase 2 trials for a Lassa vaccine started. Phase 2 trials is when you're introducing the vaccines in a population to test for safety, how safe it is, and how well it would work. And it's happening in Nigeria, in FCT, in Ghana at the Noguchi Hospital, and in Liberia with a group called Prevail, a US-Liberia partnership. So there is some progress with vaccine development, but we're still a long way from developing a vaccine against Lassa fever. And I guess the final thing I would say is Nigeria has the highest burden of Lassa fever. In some ways, it drives my passion. It's almost like I feel a sense of responsibility towards working on a disease that affects people. But the flip side of that is the country is showing up very strongly in the Lassa fever research and surveillance landscape. So, for example, if you want to understand Lassa fever as a disease and you search for a publication, most of what you would see is coming out of Nigeria. There are loads of partnerships between Global North, as people would say, institutions and Nigerian institutions. There are groups like Irwa Hospital, Abakaliki, Bauchi, Federal Medical Center, Owo. These are hospitals and centers that are in sometimes remote rural centers, but they are putting Nigeria on the global research and development map just because of how much work they are doing on Lassa fever. So hopefully that tells you a bit about the disease. 60 years after, still no vaccines, no therapeutics, and people are dying every single year from the disease.
Wow. Okay. So that was quite a lot to take in. We're going to come back to Lassa fever, but before we come back, I just want to ask a couple of quick follow-up questions. So first of all, you mentioned 300,000 as the global number. So roughly, what is the number? What percentage of that is happening in Nigeria? And second of all, you also mentioned a number of states. Is there a Lassa fever belt, in Nigeria? And is there something that links them? I don't know, weather or, just so happens.
Yeah, that's a good question. So the 300,000 is an estimated number of infections. And I'm trying not to be too technical, but I think it's important to differentiate infections from cases. Now, Lassa fever is a disease where a person can be infected, but they show no symptoms or signs, and they actually recover from it. So, someone can go to work every day and actually be infected, but not fall sick. Now, it's estimated that about 300,000 people globally are infected. The numbers from Nigeria are between 70 to 80% of that. So majority of the burden of disease or infections come from Nigeria. Do we have a Lassa belt? I mean, we could launch one on this podcast. I'm joking. No, we have states in Nigeria where there's a high number of cases. I mean,
Every year?
Every year.
Okay.
Every year, for sure, that Edo State, Ondo State, Ebonyi State, and more recently Bauchi State are at the top of the chart. And NCDC does a chart every year. And most times you see the cases spike between November and February, which is during the dry season. So there is some research to understand that, people say things like during the dry season, there's a lot of bush burning. And so the rodents are chased away. from their natural habitats and they come in contact with people. People also say, in those communities and in places where you mostly find Lassa fever, there's poor sanitation sometimes. So people don't store their food properly and therefore they're exposed. But then the flip side is also in Irwa, in Owo, and in Abakaliki, that's in Edo State, in Ondo State, and in Ebonyi State. Those three towns or cities, or however you would call them, actually have Lassa fever laboratories and treatment centers. So the more you look, the more you find.
You see, yeah.
I wonder how much we would find if we were to set up centers in some more rural settings in Nigeria. So do we have a Lassa belt? At least we know where we see cases every year. Do we fully understand why? No, but there are several hypotheses from climate and ecology to how people store food and sanitation and even to health worker settings. You would see an increase in cases where there's a poor index of suspicion among health workers and where people are not protecting themselves.
We're going to come back to Lassa fever. I just wanted to flip a bit back to COVID, right? So Nigeria managed to mobilize us, and during COVID, there was an effort, right, that came together, even though there were limited resources. On 1914 Reader, I did a review of Dr. Chikwe Ihekwazu's book, and he really described the challenge of working in that period where pretty much, you're fighting for vaccines, fighting for everything, right, to get anything. But a lot of people say that the response was ad hoc and kind of like personality driven, right? Maybe the people who just happened to be in charge at that time had that force of character, that sort of thing. But in your view, what structural weaknesses in Nigeria's health system did COVID really expose? And, how can those gaps be prevented from reappearing in any kind of emergency or pandemic that happens again in the future?
That's a bit of a tough question. During the pandemic, so I had moved to London, of course, but I went back to Nigeria on holidays at the end of the year. And I remember my brother fell ill. He got infected, got COVID, and I had to drive him to the This Day Dome in Abuja, which had been set up as a treatment center for COVID-19. And, we got there and he was going to stay. There was so much effort to set this center up. And the health workers were obviously trying very hard and were very supportive and showed care and were working hard. But it was hard for us to decide to leave my brother there. And I think it boils down to the capabilities around managing infectious disease cases in Nigeria, which is very linked to Nigerian hospitals. So again, anyone listening to this podcast and even you, Toby and Faye, that has gone to a Nigerian hospital, you enter there and you want to leave, especially public hospitals. But that's where infectious disease cases are usually managed. The standards are just not what they should be. You go to a hospital, sometimes you don't even have running water, or sometimes power supply is on and off. Just imagine going to a hospital where you have a headache or you have malaria and there's no water, there's no light, you're uncomfortable. You can bear it. But when you have an infectious disease like COVID-19 or like Lassa fever, it's harder. You're isolated, which already does something to you mentally. You're pulled away from everything, and then your environment is just not supportive. So I guess the first thing that it really should is just that you cannot build a mansion in the middle of a slum, even though people do that in Nigeria.
Yeah.
You cannot assume that you would have an excellent infectious disease outbreak response when the rest of the healthcare system is so weak. And so that's something that came out for me with the COVID response. The private sector stood up and they did things like supporting the establishment of treatment centers in places like This Day Dome. And I don't know if there were others in other cities, or I don't remember if there were others in other cities in Nigeria. But just that whole infrastructure around healthcare delivery in Nigeria is so weak that trying to build that in the context of an outbreak response or a pandemic response is hard. So that's one thing. The other thing that I would reflect on is just the politics of healthcare system delivery and pandemic response, etc. I think a lot of it, and I do agree that a lot of it was personality driven, and it's interesting to think about it. Of course, the Nigerian CDC had a strong leader in Dr. Ihe Kwazu, but you also had strong leaders in some other agencies like the NPHCDA at the time, NIMAR, etc. And then you had strong leadership from the Federal Ministry of Health and from the federal government, in the sense that President Buhari, as Dr. Chikwe wrote in his book, let the response go on. He let the technocrats lead. It wasn't like in the US where we saw the president at the time intervening so much in a terrible way. But even with that, you still had a lot of duplication, in my view, and different groups working. So, it was almost like every agency was doing its own type of communications, for example, and sometimes you would have varying messages. And then, if you again try to think back, the whole palliative thing and the fact that during the pandemic, Nigeria CDC, NCDC was advising, don't go out, avoid crowds, don't go into people. And on the other hand, another government agency was sharing palliatives and telling people, come and line up. Or at the same time, around the same period, that's when the government decided that we all had to get NIN, the NIN thing. I remember joining queues and being so worried. Of course, I was wearing a mask and trying to stay, but how do you stay away from that context? And it's hard to juxtapose with a place like China where it's extreme. Everyone was following one direction. And then you compare to a place like Nigeria where different agencies were creating their own messages and creating their own rules that sometimes did not help and defeated each other's purpose. So you have one agency say, don't gather, and you have another agency saying, gather and come and do your NIN or come and take palliatives from us. And just talking about the palliatives bit, I think the lack of social safety nets in Nigeria was one of the things that really, really hit me hard personally. You guys are the economists and you can tell me more about this, but I think a large number or significant part of our population earns daily in Nigeria, and people feed because they can go out and sell in the market, for example, and make money and then buy food to feed their children or feed their families. And then all of a sudden, the government is saying to them, don't go out, don't do anything, stay at home because there is a virus. I mean, how do you tell people not to feed because there is a virus? Of course, to you and I, perhaps we're privileged and we understand it and we can stay at home and we can afford to back up, buy things at home and keep and store and all of that. But then how do you explain that to the average person who has to go out to feed when you're not providing them with any social safety nets? And again, it goes back to the whole palliative thing. I think the government did try, but it's not possible that during an emergency, you then start to create a social register, for example, which we don't have as far as I know. But was this talk about, giving palliative to the poorest? Well, who are the poorest? Like, how do you even define the poorest? How do you give them what you want to give them? And also, I think the third thing for me there is that lack of social safety nets was painful because you really want people to stay at home, but how do you reconcile that with the fact that they cannot feed or make a living, or even for children who couldn't go to school? Again, people were privileged where some schools went online, but it's a real privilege to be able to go online. How many schools in Nigeria actually have that access? So yeah, I think those three things, the lack of social safety nets, the forceful creation of a system within a system that doesn't work already, and then the lack of political alignment in some cases were challenges that we faced then. And I suspect that if we have another pandemic now, we will still face the same.
I mean, that was a lot to take in, actually, because you talk about Nigeria on different issues, and the problems always sort of revolve around the same set of constraints or dysfunctions. During COVID, I recall vividly when the palliative madness got to my neighborhood, and there was a government truck that literally came, and local government workers or whatever were just tossing food at people, like on the streets. And this was at a time where we had food delivery companies in Nigeria. It's not like the logistics is so hard or you can't find private partnerships to do that more sensibly and coherently. But I mean, to follow up a bit on Fihi's question, Do you think part of the problem was political centralization of decisions? Did it help or hinder outcomes? And how should state level health security capacity be restructured so that so much is not dependent on the capital, right? And what will a sustainable model of coordination between NCDC, state ministries, and other stakeholders in the sectors look like in practice?
Okay, heavily packed questions, and I'll try to remember each of them. Did political alignment help? I think it did. So, there was a presidential task force on COVID-19 that was established, and it was led by not the chief of staff, the secretary to the government of the federation. And he provided the political leadership. And then there was technical leadership by people like Dr. Sani Aliyu, who was at the time had just been the director general of one of the health agencies of NACA, and people like Dr. Chikwe, of course, and several other colleagues. And I think that really helped in mobilizing the thinking in the health sector, but also across board. And I remember, they used to have these daily press briefings, and you'd have, what was Mr. Lai Mohammed's position then? He was information minister, right?
Yep.
Yeah.
Yeah. So, yes, so you'd have Mr. Lai Mohammed, or I don't remember his title, Lai Mohammed.
Laji Lai Mohammed.
Lai Mohammed.
Some might say misinformation minister, but go on.
I think one thing the presidential task force really helped with was, bringing the Minister of Information, Minister of Health, and the various ministers, the private sector together to align. But one thing that did not work well and relates to your next question is that state level. So I don't know if you remember, and Faye, you might have seen it in...
Yes, I think I know what you're going to talk about. Kogi State, sir.
Oh, why not? Kogi State during the pandemic. It's funny because there's this meme that people still use where the state commissioner for health was actually crying on live TV.
We don't have the facilities.
We don't have, actually crying. But, there were states where, despite the fact that there was a presidential task force, there was a presidential mandate and all of that, they still did what they wanted to do. So, Kogi State...
The governor was just a ridiculous person.
Extremely, and hopefully we're safe to say that. But, it's just interesting. How can your state is bordered by, I don't remember the number now, 4 to 6 other states. Kogi State is one of those states that's bordered by several others. And you know how the borders in Nigeria are, you're literally crossing a rope to jump from one place to another. Now, all these other states are reporting hundreds of cases and deaths. And you're saying my state is safe. Like, what have you done in the world to say that your state is safe? And not just that, but the fact that people had signs and symptoms of COVID-19 in states like Kogi, and the governor would refuse for them to be tested. And so you were not just playing a political game, but you were playing a game that could have led to deaths of people. Because, at some point, there was no testing capability because the governor wouldn't let that be set up. So I guess my point is, I don't know what the solution would be. And at some point, I was quite obsessed with thinking about the decentralization of healthcare and health systems in Nigeria. How do you manage the laws or the rules, but also the implementation of them so that when there is a pandemic or a large outbreak, a state is not choosing to do its own thing? One of the things that struck me then was there was no, and I think there is still no, I haven't followed the laws recently, but anyway, during the COVID-19 pandemic, there was actually no law mandating states in Nigeria to report cases to the Nigeria Center for Disease Control or to the central body, the Ministry of Health or whoever. So a state might decide, well, we decide that we don't want to say that we have COVID-19, and that's all. All you can do with them is negotiate. There's actually no law in place that requires them to do that. And I don't know enough to say, the solution should be make a law or whatever. I guess the solution is let's elect the right leaders who actually care for us and care about health and public health, but also just thinking about states and what is sustainable. I remember when I worked in Nigeria CDC, there was a large cholera outbreak like many years ago. And the states, as they usually would, wrote to Nigeria CDC asking for support. And they were asking, I mean, it's really embarrassing to say this, but they were asking for things like soap and bucket. Of course, you need soap and bucket during cholera outbreak, but how does a state, States have their own allocations, they have their own funding, they have resources. And, some states are richer than others. But how does a state actually have to write up to the central body, to the Federal Capital Territory, to ask for soap and bucket? Buckets are, I don't know what the amount would cost now, but then it would have been $1 or $2 to buy a combination of soap and buckets for each person. And let's estimate, okay, maybe you needed 1,000 of that. So we're talking about $1,000 here. But there is just this incredible level of dependency on the central level. And it's almost like the states have relegated their responsibility for healthcare, health system delivery, outbreak response to the central level. So when there's an outbreak, you have people going from Nigeria CDC to the states to help them. And I don't think helping is bad. It's the full dependence that I think can be a challenge. Of course, there are some states that are doing well now. And again, for me, it boils down to leadership. So shout out to states like Ekiti states, like River State, with people like Dr. Banji Fulani, Dr. Adeze Ore, who are or were the commissioners for health. You see the difference there. You see that now they actually develop an epidemiological report to tell you what number of cases they have. It's sometimes even the very simple things. But all of that cannot work if you don't have the right resources from the government. So, you can have very smart people be commissioners for health and you can have them do everything. But if there's no funding, there's no funding. They will still beg for soap and buckets. So I guess the sustainable model is that states actually dedicate enough resources into healthcare and epidemics. There is a series called The Outbreaks That Didn't Happen that is done by a group called Resolve to Save Lives. And I have a few friends who work there. And what that series tries to do is sometimes I think political leaders don't realize the extent of risk we are of infectious diseases because, if there's a case of Lassa fever, for example, in a small state, for example, and very quickly that case is controlled, the case is isolated and then they get well and nobody else is infected. It's controlled and it's quiet and nobody thinks about it. It's an outbreak that didn't happen. Now, because there are so many outbreaks that didn't happen thanks to excellent work by people, sometimes our political leaders don't think about the risk of outbreaks. And that's why when you compare things like that to COVID, see how everyone was jumping up. The private sector, at some points there was even in the news, some private sector companies, and I will not call their names, were actually putting out press releases and fighting because one group gave funding for vaccines and another group said, oh, why didn't you work with us to give funding? So there was actually fights to support because everybody realized how much of a risk this was. But when you go down to other infectious diseases that don't happen, people forget, political leaders forget. And, something I hear people say is, you hardly hear state government or even the federal government go to Geneva or New York to ask for money to build bridges or things like that. But why do you hear them go to those places to ask for money to strengthen their disease surveillance system, for example, or to ask for money to buy soap and buckets? It's because of how focus they put on it. So I think the sustainable model there really is how do the subnational level put in sufficient resources so that they rely less on the central level, on the Nigeria CDC and others during an infectious disease outbreak, whether in preparing for it or in responding to it.
So I want to talk about vaccine access, which is also an area where you work on. And this also became an issue during COVID. Vaccines, diagnostics, and even PPE. I mean, there was the famous tweet to Elon Musk begging for PPEs. And I mean, this also exposed how tightly linked to the global supply chain that these things are. What practical steps, again, using what you experienced during COVID and also from your work generally in public health, what practical steps can African nations generally, even moving beyond Nigeria now, take to reduce dependency, especially on donor arrangement types, dependencies that, puts you at the back of the queue, more or less, but without retreating into, self-sufficiency that is neither realistic nor cost-effective?
That's a very smart question because especially the last part, without retreating to self-sufficiency, because, I think we've gone from, there is very limited capacity to manufacture vaccines diagnostics for testing and all of that in the region to now every country wants to set up vaccine manufacturing. I was, and it's like, and the question I keep asking myself is, if everybody is manufacturing, so who is buying from who? But also, I think more political leaders need to realize that vaccine manufacturing is not as simple as deciding to manufacture pencils, for example. There's so much that goes into that entire landscape. So I think let's talk about numbers first. At the moment, less than 1% of the vaccines that we need in Africa are actually manufactured in the region. So we're dependent externally on 99% of what we need. The other thing to think of is when people think about immunization and vaccines and how many vaccines you need, there's something called a birth cohort that you use. So a birth cohort is how many children are born in a year, because children would need, vaccines. There's routine immunization, a number of vaccines in their first few years. Now, Nigeria's numbers, at least as of 2022, was about 7 to 8 million. So it means that every year, for sure, at least 8 million children need vaccines, and various vaccines at various number of doses, etc. So we actually have a big market in Nigeria and in the region. But I don't think that everyone going into self-sufficiency is the right step, because the economics of it is just not right. What my doctorate work has been trying to do is really understand Nigeria's plan. And I try my best to be optimistic, right? Because we have the market and that's what everyone says. But there's so much else that goes into it beyond the market. There's, if you're manufacturing vaccine, you cannot afford to say, the national grid is down. So therefore, the vaccine we were supposed to manufacture, we could not finish manufacturing. You cannot afford to do that. You cannot afford to say, we finished manufacturing, for example, and we're sending the doses from, let's assume, from Lagos to Benue, but, NIPOST said that you cannot find it again, or that customs seized it when it was being exported to another country because somebody did not sign a form that they could not find somewhere. So,
They were asking for money.
So, just the broader landscape of it is so tricky that I feel like if we focus too much on the technicalities, and we're doing so, we have a very ambitious and positive Minister of Health. We have a presidential group that is looking at unlocking the healthcare value chain in Nigeria. Like, we have people working on the technical bits, but those people do not have control over the power supply or the water supply or the logistics of transporting vaccines and all of those things. So I guess the first thing to say is, even when if we're thinking about self-sufficiency in Nigeria or other countries, we need to think about the enabling factors. And that's something that countries like Senegal have started to do with Institut Pasteur Dakar. That's a group in Senegal that has been producing yellow fever vaccines for so many years, I think over 50 years, if I remember correctly. And it has worked, and they're now expanding capabilities. So there's so much to learn from neighboring countries in terms of, it's not just about the vaccines, but, even the people. And people say, oh, Nigeria is blessed with so many people and, population is not our problem. And there's the argument whether it's brain drain or it's exporting talent, etc., which we shouldn't get to. But when you think of the trained people, like our university curriculum are not whatever the English is, are not set up for the science that we need. Someone who I really admire, Professor Oyeronke Oyebanji, in one podcast said Nigeria is training scientists for the 19th century. And I'm paraphrasing her, but she teaches at the University of Ibadan and she's an academic. And so she knows the curriculum. And what she was saying is there's so much advancement in science, but our curriculum is still like many, many, many years behind, that it's very hard to reconcile that with an ambition to leapfrog. So I guess that's one piece around how far can we go. The other piece is what helps a lot of quote unquote Western countries in advance of pandemics or outbreaks is that they set up contracts. So for example, with Mpox, for example, Some countries actually had contracts with manufacturers of smallpox vaccines that are now licensed for mpox. Mpox is what used to be monkeypox, such that when there was an outbreak, those countries could access the vaccines. These countries also create what you call stockpiles, so that you tell the company or pharmaceutical company X, there is a virus, you have a vaccine for it. We don't have the virus in our country now. There is no outbreak now. But when we have it, we want to make sure we have X number of vaccine doses available to our population quickly so that it is accessible to us. But that's not what you find. When you read about countries that do that, they're mostly high income countries or sometimes upper middle income countries. And sometimes it's not for the lack of resources, but it's also for the lack of planning. It's almost like we want to wait until there is an emergency before we start thinking about things like that. Another thing I have, thought of recently is just the whole indemnity and liability thing. And I'm not a lawyer, so, forgive the languages I use to lawyers who might be listening, but the simple way to understand it is if you have to introduce a vaccine to a population at speed, and sometimes where the vaccine has emergency authorization, so you're using it in an emergency phase, somebody has to take over the liability of that. So if there's anything wrong, it's not the manufacturer, it's, the government or whoever. Many countries in the African region do not have those clauses set as standard, such that with every outbreak, it's almost like you're negotiating from start. And that's one of the things that was a big problem during COVID. So I feel like a sustainable way to think about access to, and I've spoken about vaccines a lot because that's where I work, but it's access to vaccines, diagnostics, therapeutics is beyond the manufacturing. How can we set up the partnerships that will enable us access quickly when there is an outbreak? I mean, Nigeria has partnerships with India for several things. There's the health tourism bit. India houses the largest manufacturer of vaccines by volume, Serum Institute. How about we sit down with them and we think through, okay, you already manufacture vaccines. We have a big market here. How can we set up a mechanism such that, you produce vaccines to our big population at an agreed cost and at an agreed frequency, and we pay you, we don't depend on any donor. And if there is an outbreak or an emergency, how can we set up clauses? And again, it's very tricky because what usually happens and what we saw during COVID is when there is an outbreak, it's survival of the fittest, who can pay the most.
Yeah.
And there was a lot of criticism because sometimes the vaccine manufacturers or vaccine developers or producers themselves were not open about the price. So, a manufacturer might sell a dose, for example, for $5 to this person, and then someone comes to offer them $10. And of course, sometimes it's for profit, it's for business. R&D, research and development is so expensive that you want to recoup the cost. And so what happens is that during an outbreak, it sees survival of the richest, who can pay the most. And this sense of charity or equity doesn't always work then. So, in my view, and, if I had a magic wand, I would be thinking more towards how can we set up the systems, the partnerships such that we're not stuck at the back of the line. We will not be in front. I don't think Nigeria would be able to outperform the US, for example, when it comes to buying vaccines in terms of availability of resources. But how can we make sure that we're much closer to the front of the line than we are at the moment, while still thinking about local manufacturing? But even within Africa, how can we think about a few countries? If Senegal is manufacturing vaccines already, do we really need extra countries within West Africa? Yes or no? I mean, people might argue different ways. Or can we say, oh, XYZ vaccines are manufactured in Senegal, so another set of vaccines for a separate set of diseases or a different platform would be manufactured in another country? So thinking regionally, I think would also help. But if we want to drive towards self-sufficiency, we shouldn't forget the enablers, the economics of it, the power, water supply, the educational systems, and everything else that would need to work if vaccine or diagnostics or therapeutics manufacturing in the region was to work. Nigeria has just started manufacturing bed nets. I think there's a slide. Well, no, I know it sounds funny, but do you know how much we were spending importing bed nets? I mean, most of it is donor supported and driven, but the fact that we now have, I think it's in Songo, Ota, or somewhere, a place in the country that can manufacture that is, I mean, it's an achievement. It's an achievement that is coming decades late, but it's still an achievement, and it gives me hope. And there is a lot of manufacturing of pharmaceuticals, of drugs in Nigeria already, but we still don't have any sites that can develop the active pharmaceutical ingredients in Nigeria. So what you have is people are still manufacturing those ingredients, and then they do the final stage of drug formulation and then sell. But if we can start manufacturing active pharmaceutical ingredients in the country, and EMZO, for example, is working on this, I think we would make a lot of progress. So, there is progress and there are things to leverage in terms of what has been done so far, but we're still a long way from that sufficiency, self-sufficiency.
Okay. I wanted to come back to Lassa fever now. So your work, you've cited some modeling that suggests that there are large health and economic benefits from vaccination for Lassa fever. What target product profile and delivery strategy makes the most sense for Nigeria? So I'm talking about a vaccine now for Lassa fever. Should the focus be on a reactive campaign, or should priority groups be like, say, prioritize groups like healthcare workers? And who is the credible guaranteed buyer in a hypothetical world where Nigeria no longer gets Gavi support? And I know there have been conversations around this where Nigeria has overstayed on Gavi, if you like. I mean, these resources they're finite, so the more Nigeria consumes, the less other countries can consume, that sort of thing. So who could replace Gavi if we had that kind of hypothetical scenario?
Who could replace Gavi in terms of buying vaccines for Nigeria? The Nigerian government.
Okay, well, and then to start off with, obviously, Lassa fever specifically for,
Yeah. I will come back to the Gavi question, but what could be an ideal target product profile? Again, I will take a bit of COVID experience here. There were different vaccines made by different manufacturers. There was AstraZeneca or Oxford, depending on who you ask. There was Moderna and there was Pfizer. And I think that was the first time where I started to hear people say, oh, me, I don't want this, so I want that. But from a technical perspective, I think our experience then was the Pfizer vaccine, which is an mRNA vaccine, needed ultra cold chain requirements. And I remember working with an excellent team with an Excel sheet just to map out which countries have ultra cold chain facilities, because the countries that do not have them could actually not get that product because you're basically going to send the product to waste. So if you're not able to maintain the cold chain, then you can't really use the vaccine. And as you would guess, most of the countries without those capabilities were low and middle income countries. Of course, Nigeria has some, and Nigeria has a very strong immunization program and system, but the capabilities are not everywhere. Again, when you then add the problem of power supply and whether the national grid failed or not, there's a whole thing. So I guess the answer to what would be an ideal target product profile for a Lassa fever vaccine, when you juxtapose that with the context of where a vaccine would be used in rural settings, in countries like Nigeria, Liberia, Guinea, Sierra Leone, where the health systems are not very strong, you definitely want a thermostable vaccine. You want a vaccine that can be moved to rural settings and doesn't require very expensive storage. I've never worked in immunization, and so I'm always fascinated when I hear things like, or sometimes during an outbreak, if you vaccinate, I can't remember what this person was talking to me about, but basically they were saying nomads, people who move around, like herdsmen, for example. If there's an outbreak somewhere and you say, oh, we want to vaccinate everybody and it's 2 doses, so you give the first dose and then you come back next week, where would you go to start looking for the herdsman to give him, his or her, their second dose? But also, if you introduce a vaccine and you introduce it outside of the routine system. So one thing that works for mothers especially is, when you take your children, they'll say, oh, come out 1 week, they'll give you this vaccine, come out 2 weeks, come out 6 weeks, things like that. And then you put one that is completely off the field. It's very hard to track that because not everyone has a mobile phone. And it's such a privilege to think about the fact that I could put a reminder, or I can tell Alexa to remind me in 2 weeks. But how many people actually have that level of access? And there are people working on innovations, on immunization reminders and all. But until then, when scientists, when developers design vaccines, they need to have that context in mind that you want to, as much as possible, avoid vaccines that would require follow-up. It's not always possible because of the science and the platforms of technologies and all of that. But an ideal vaccine should be 1 dose or 2 doses. By the time you start getting to 3 doses, you are getting to a very high risk of not seeing people come back for different reasons, whether financial or interest or because they moved or whatever. So the target product profile could be that. In terms of whether it should be reactive or preventive, it's very hard to say because we don't know enough about the vaccine yet to say how long the protection is for. So, for example, if this is a vaccine that would give 100% protection for life, which is, very, very hypothetical and very unlikely, but let's assume this is 100% protection for life. Of course, if you give people once, that's it. You don't have to think too hard about it. But if this is a vaccine that would give only 50% protection for, say, 6 months or 12 months, then you want to plan around outbreaks, or if we know when there's an increase in cases, then we vaccinate people just before and we vaccinate people who are at risk. So I guess it's very hard to say whether it should be preventive or reactive because we don't know enough about the vaccine and the situation will depend on that. But I'm glad you asked, Faye, because the work I do sits between combining R&D with policy. Like, it's very important that scientists are not working all the way to the left and then the people who are introducing the vaccines are working all the way to the right, because what you will then have is a very, very nice, shiny product that cannot be delivered because the context is so different. In terms of who would be the ideal buyer of a Lassa fever vaccine, that keeps me awake at night because, firstly, we're talking about a vaccine for a disease that only affects a handful of West African countries. So you can think of this economically as well. If people use iPhones, for example, I could use that as an example. Everyone is going for the 17 or the 17 Pro and all, and there's a very huge market. And I don't know what Apple's manufacturing rate is, but they can produce enough because they know there is a market and people will continue to buy. Now, with a disease like Lassa fever, when you compare it, the number of people that need a Lassa fever vaccine are in just 4 countries in the world or 5 countries in the world, if you think about it. And within those 5 countries, it's not everywhere. The number of cases you see in Lagos is not the same as the number of cases you see in Edo State. Now, within that, if you think about it, these are poorer states and all, which is why people say, or, you could call Lassa fever a neglect. What this means is that before you even think of who would buy, you need to think of an attraction for a manufacturer. So who's going to take on the risk of manufacturing so many doses when they don't know who would buy? The countries that will likely use them are Gavi dependent, so they depend on a donor to buy vaccines for them. But if this donor says, oh, this vaccine is not on our list, then there's a big question mark as to who would buy them. And this is why, or where I hope the government would really step up, because I think for once we would be faced with dealing with a problem that is our problem. When you think of things like measles, like rubella, these are diseases, vaccine preventable diseases that are not just in Nigeria. You find them in the US, you find them in the UK, you find them, so there is a market even for cholera where it's a bit more tricky, but you find cholera, Southeast Asia, Africa, in other regions. But for Lassa fever, if Nigeria doesn't step up, nobody is sitting down and waiting for a Lassa fever vaccine, except the virus changes and we get a Lassa fever pandemic. I hope not. But until then, if the governments that have the highest burden of cases do not stand up, then we're in trouble. The Africa CDC, the Center for Disease Control for Africa, which is an agency of the African Union, an independent agency of the African Union, I think, is trying to create a pooled procurement mechanism for vaccines. What that means is that, they would buy on behalf of countries and the funds would come from hopefully the member state funding that goes into the AU pool. Now, that is a potential mechanism. It doesn't exist yet. We keep hearing, it's being worked on. But that's a potential mechanism for these sort of diseases that are not globally critical to rich countries, but are so critical to countries in Africa, even some rich countries in Africa. So I think having a pooled procurement fund that is run by the region is important. ECOWAS, through the West African Health Organization, is also trying to set up a similar fund so that they can purchase on behalf of the region. But there's a lot of talk, and the heads of states agreed on this years ago, but it hasn't really moved from talk to action. But that's a potential mechanism in terms of who would be the buyers. The governments, I guess, whether it's governments as sovereign bodies or governments through regional institutions like the AU or ECOWAS.
That kind of reminds me of a story I read quite a while ago about the vaccine for sleeping sickness. What's the scientific name? Is it trypanosomia? Yeah. Basically, the company that was manufacturing it just stopped because it did not make any sense for it. And this is a disease that is centuries old in Africa.
Yeah. Let me find out your R&D side a little. Uh, so if you run a time-tested Lassa vaccine pilot in states with a high burden of them, I know we've talked about Edo, Ondo, Ebonyi, Bauchi. What evidence will you need to see before it can be scaled? The kind of things you need to get the WHO, for example, to pre-qualify the vaccine and get a credible buyer, right, to guarantee production.
Toby, you have to tell me if you have an R&D background, because this is a very R&D question that even I will struggle to answer. But I guess it's an interesting question because it's still being thought through. So the usual model or the traditional method for vaccine development is you do a phase 1 trial, and then you go to a phase 2, and you go to a phase 3. And with each phase, you're increasing the number of people that you're exposing or that you're testing the vaccine among. To put it very simply, you're increasing the population size. And what you want to see is how effective is the vaccine in an endemic setting. So in a place where people would likely have vaccine and you're doing a clinical trial and you introduce it, how many people are actually protected and are you seeing a decline in cases? Again, that number is still being worked through. But I've heard people start to talk about things like alternative models for vaccine licensures. Clinical trials are important and will continue to remain important. But there are questions like, could we better understand something called the correlates of protection? So what antibodies are created when people are exposed to a vaccine. And in that way, you don't need to wait until you have like so many trials and so many people exposed, because you have an understanding of the correlates of protection. And, there is some funding that has just gone in to do work in Bauchi, in Edo, and in Sierra Leone, in Kenema Hospital, to understand this whole thing about correlates of protection. And hopefully you don't ask me more about it, because that's all I can say. But we don't know enough, I guess, is the answer to that question. There are still ongoing phase 2A trials in 3 countries, Nigeria, Ghana, and Liberia, to even help us understand how safe is this vaccine before further studies are done. The vaccine has not yet been tested in places where you have cases. So even in Nigeria, for example, the clinical trial is in FCT in Abuja. Abuja or FCT is not an endemic area. It has to be tested in places like Edo, Ondo, perhaps Bauchi, Ebonyi, to even get further evidence for whether it's WHO pre-qualification. And to throw another thing in the mix, there's a whole question around if we need, because usually with vaccine approvals and licensure, you'd usually wait for what people call stringent regulatory authorities, so like the US Food and Drug Agency or the European Medicines Agency, to sort of approve. And then if it needs to be bought by groups like Gavi, then WHO pre-qualification and others. But the mix here is that countries like Nigeria, because their regulatory agency, so NAFDAC in this case, are getting stronger, and at a certain maturity level 3, we might not even need to wait for WHO. It could be that NAFDAC is able to make a decision to say, actually, we've seen enough, and based on the data, based on the immunogenicity and the safety and the efficacy of this vaccine, we're able to approve. WHO pre-qualification is still what is needed for some donors to buy a vaccine. But in terms of can it be used, even NAFDAC could possibly say. I'm not saying that NAFDAC will. There are still discussions, but I think I'm throwing that in to say that that's an opportunity for the country and the region to show leadership, because, again, this is a regional problem. We're developing a regional solution. We don't need to wait for the US or the European government to help us approve. Our regulatory agency is at a maturity level that it can. Hopefully it maintains that level because there is some maintenance to be done, and that's checked, I think, annually or at a certain frequency that I don't remember. But that would mean, us showing and providing the leadership that is needed.
I know you're focused on a lot of your work, your professional work is mainly on Lassa fever, but if you were to step back and say, okay, if Nigeria had to pick one first success for local production of vaccines, and the answer could be Lassa, but if Nigeria had to pick one first success for local vaccine production, what product would you prioritize and why? And would you go with something that proves it can scale or target something where Nigeria can lower the existing costs of production? Or again, go with a region-specific trend like Lassa, giving your work's emphasis on assured markets and price competitiveness and that sort of thing.
It's very hard to say if I should answer that economically or politically or R&D wise or emotionally.
Economically. Let's start with economically. Yeah.
I think it's a mix of it. It's very hard to choose one, but I would focus on childhood vaccines. And I say that because I think to introduce vaccine manufacturing, you have to have an assured market. And every year, Nigeria has a birth cohort of 8 million. That's already something. Secondly, you want to start and grow from a particular level. Like, you don't want to jump into it. And so you want to start from vaccines that are already produced. And so the technology can be transferred to Nigeria.
Sorry to interrupt you. So those childhood vaccines you talked about, where does Nigeria currently get them from? So things like, say, I imagine you're talking about things like measles and all that stuff.
So they are largely procured by UNICEF with funding from Gavi, and most of it comes from Serum Institute of India.
Okay.
Serum Institute of India is where Nigeria gets its vaccines from, but most of it is like through the middleman here, which is Gavi, UNICEF. And there is a partnership, at least on paper, there is a partnership between the Serum Institute of India and Nigeria for local manufacturing of vaccines. So how about we start from that technology transfer? Now that's, I think, the politically correct answer. The economically correct answer is, it's again tricky because my best example of this is Air Peace and British Airways. People were saying, oh, Air Peace, you can fly Air Peace for 1,000, for example, £1,000, but British Airways is £1,500. Air Peace is coming to take over British Airways, London to Abuja or London to Lagos markets, yada, yada. But I think British Airways has made enough money and market to a point where if it decides to take a short-term cut and reduce the cost of traveling, the cost of tickets, people would still buy. But if Air Peace decided to do that, I don't think it would survive as long because it doesn't have that, economic standing. So that's the same thing with that's how I think about vaccines. I think that if a Nigerian company decides to start manufacturing vaccines today and it says, oh, I'm selling this vaccine for $10 a dose, Serum Institute of India, I think, based on the volume it produces and how much capital it has, can decide that, okay, well, we're now selling ours for $4. Now, I guess I'm going to throw the question back to both of you. If you were the president of Nigeria and a Nigerian company is selling something at $10, but an Indian company is selling it at $2, which one would you go for in terms of planning your annual budget?
So I think the answer is typically easy. There's a way Nigeria does the thing. Now, if it was Nigerians paying for it, then obviously the government will go with $10 one. Somebody will make money. They'll ban, it will ban the Indian one. But in this case, you have a challenge of whereby who's going to pay for the vaccine.
Yeah.
I mean, the children, you are vaccinating children, they are not going to pay. So I guess the usual approach of, say, we'll just ban the Indian one and in the name of saying we want to protect the local industry, that's all. It wouldn't apply here in this case because, I mean, Nigerian government will pay 5 times the cost just for the no way. They wouldn't do that.
Exactly. So
I think another possible solution would be that you usually get a rich person that will set up a fake vaccine production company, order from India, and then rebrand it as patriotic Nigerian-made vaccines.
Yeah, that's also an option. Yeah. Well, ultimately, I think it comes down to who will pay, right?
exactly, who would pay? And I think I'm really grateful that the systems for vaccine manufacturing are so stringent that would be, I hope, impossible. But I guess the thing you learn from Nigeria is never say never. That will shock you, as they say. But I hope that it would be completely impossible to do that. But anyway, I think my point really is sometimes you have to think economically as well. And Gavi has actually set up something called an African Vaccine Manufacturing Accelerator, which is supposed to support local vaccine manufacturers and subsume some of their costs so that if they're just entering the market, they can sell at a lower price and compete favorably. But again, that is still donor support. That is still a lot of dependence. It doesn't get us to that point of independence. And there's so many loops, you have to be, your product has to be, I think, if I remember correctly, WHO pre-qualified. You have to work in a country that has maturity level 3, and there's only a handful of countries in Africa that have that at the moment. So there's so much, it's not just as simple as I want to manufacture a vaccine, Gavi, give me money. There's so much you still need to do. So I guess it's tricky. And it actually happened in South Africa. I was trying to find the name of the company, but I can't now. But there was an article written by a civil society group that was actually criticizing the South African government for importing those vaccines because they were buying them for cheaper. And I can see the perspective from a vaccine equity health system development perspective where you're saying the government should support, locally made and all. But from an economic perspective, I mean, governments would always want to do what's most cost effective to them. And it's like short-term cost effective. They're probably not thinking about, in the long term, if we support this company 50 years from now, the vaccine will be lower. For that president, in 50 years, he's not going to be there except he's a certain person. But, for that president, it's more about how much money am I putting in now and saving from it rather than what is the very long-term game here. So I guess the answer to your question, it's very hard to choose. And Nigeria is doing different things, A Nigerian company was selected by WHO as one of the hubs for mRNA. So mRNA is a new technology for vaccine development. And, they're trying to jump into mRNA, which would require ultra coaching and all these things. And sometimes I'm just nervous about it. I think, yes, we should leapfrog our science and we should do more advanced things, but maybe we should start from small things and grow from there. I don't know. Yeah. Oh, by the way, do you know that we have a vaccine manufacturing company in Nigeria? It's been there since 2007. I have to double check. I think it's 2007, but we've still not been able. I mean, it's a government and private sector partnership. Nigerian government, May and Baker decided to come together. Vaccine manufacturing.
Wait, sorry. What is it 2007, right? It was built in 2007 and it's not worked since then, or is that what you're saying?
It was established because when you say built, there's nothing in terms of like you can't walk into it. There's nothing to walk into. There's a piece of land that the government did give. There is a company that exists, BioVaccines, but it hasn't been able to manufacture any vaccines since then.
So it's just there. Yeah.
It's just there. It's still working. It's still working to manufacture vaccines, but I guess the principalities and powers are greater. But yes, it's very interesting. But there is actually a vaccine manufacturing company in Nigeria.
A quick question I wanted to ask, right? So you said 8 million kids. We roughly do kind of like 8 million. Do you have a rough estimate or just a ballpark figure of the cost of what does it cost to immunize those 8 million kids a year? I'm just trying to get a sense of the spending that is required. And then right now, who is footing that bill, or how much of that bill is being footed by donors and how much is footed by Nigeria?
I actually do not. But I was in a group last week talking about something else, and someone mentioned that the most expensive vaccine, childhood vaccine, at the moment is about $3.49, if I remember correctly. So if you use that and do a range of $1 or even 50 cents, because the yellow fever vaccine is less than $1. If you do that to $3.49, I think you get a cent, and you multiply that by, say, 5. Let's assume, and this is very, very wide assumptions that someone might tell me is wrong, but let's assume $15 per child
for the package, right?
For the package, and that is subsidized. So the vaccines that people get at the moment is subsidized because someone has paid. So maybe a donor has subsidized it from the manufacturing angle, and so the manufacturer is selling it at the smaller price, or that Gavi in the pooled procurement mechanism has been able to negotiate a smaller cost for the countries. So Nigeria is heavily dependent, and I'm using heavily as a qualitative term because I don't have the quantitative. So, excuse me, I don't know how much money the Nigerian government puts in to buy vaccines versus how much money Gavi does. But I know the scales are skewed, meaning there's more donor support coming into
So this is like we're talking about somewhere in the region of $100 million a year will cover this whole thing, right? Okay.
Mhm. I will check after this recording and see if I can find the numbers, because how do you advocate if you don't know the costs? How do you advocate for this to go into the budget if you actually don't know? And maybe there are people, maybe there are colleagues who work in civil society, the inner circle, but I don't think this should be an inner circle number. And it's one of those things when you think about politics and electing the right leaders, you should be able to say during your manifesto, it would cost $100 million a year to purchase vaccines for children in Nigeria. If you were elected, how much are you willing to put? Like, let's move from this, what I call shaded advocacy, where a group of people know it and they ask for it, to more public sensitization. Like I said earlier, nobody is going to New York or Geneva to ask for bridges. You're not going to beg the UN to help you build a bridge, because you know that building bridges will also get you votes and things like that, and people want to see things. But you're going to beg for vaccines because you don't regard it at the same level of a healthcare system delivery. So how about we get more public focus on why this is so important and why we need to advocate better? Hopefully your podcast will help us.
And I like the fact that you keep saying electing the right people, because sometimes doing the right thing I've found is the wrong advocacy in Nigeria. Because, when you start doing the right thing, you soon find out it is the wrong thing. 10 years ago, manifestos weren't a thing in political campaigns, but now they are, and they are completely useless. So,
Nigerian political campaign, right?
so electing the right people, I like that. Eventually, I'm going to get to this question. The Japa wave. Earlier, you talked about, we're not sure how to frame it, whether it's exporting talent or, brain drain. How do you think about should I say, the labor economics of healthcare workers generally? Some people have floated the demonic idea of banning or capping migration. I yell at them. Sometimes they yell at me back, but I think it makes no sense. Absolutely. But I'm curious how a public health expert think about this.
Yeah, I also think it's a demonic idea to ban immigration of health workers. And I mean, I'm going to focus more, when I say health workers in this case, I'm going to focus more on doctors, nurses, dentists, people that offer health service delivery in medical centers or medical facilities. Because I think when people talk about brain drain, that's when they go to. I'm separating this from people like myself who work in public health. I think, firstly, the fact that people even accept to study medicine, nursing, and all these other courses means they're very passionate. And I think it's so intrinsic, such that if the right enabling environment is there, people would stay. Of course, people would always leave for different reasons. People would leave because their families, or they want to experience another country, or they want better opportunities, etc. But people would also stay for the same reasons. And so I think brain drain it's a painful reality. And I'm picking my words because when I talk with my friends, I often say I can't believe that no Minister of Health has been able to solve the problem of Nigeria's brain drain. And I speak because I'm on the outside. I've never been a Minister of Health. I don't know what it feels like. I don't know what principalities and powers they're up against. But I just feel like if the right systems were there, if you were paying people enough, if you were supporting them, if you were creating the enablers, it would help. And I'm going to walk back a bit to when I worked at the Nigeria Center for Disease Control. People were literally begging to join a government agency. And that's something I had never seen. But that sense of fulfillment, purpose, you were coming to work in an agency where you got to fight outbreaks. And I want to emphasize the government agency part because you're coming to beg to join like level 8, level 9, the civil service system. So it's still the same pay. But people wanted to join just for that sense of fulfillment and contribution and the learning opportunities and, the leadership and the vision that they saw. So if we could create thousands of such across the country, I like to believe that the brain drain we're seeing will be different. And when you speak to people personally, some very well-trained doctors or nurses and others actually emigrate and then they do jobs that people might consider less prominent. So it's almost like they're running away from the system and the context, not from the profession. A doctor leaving to do something that is not medicine, of course, it could be by choice, but in many cases, and I think in more cases than none, people are doing it because they're running away from the context. You're running away from the fact that you're not being paid salaries monthly to collecting whatever salary you would get in another context or in another country. I also think that brain drain can be reframed in a way that is talent exporting, like I tried to say earlier. And there are countries that do that, and this is not a topic where I'm very vast in, but I've seen like videos with Cuba, for example, where they're exporting doctors to support and all. How about we do that? Like we create a system, but we cannot create it, if you go to the Nigerian embassy today now in London and you say, okay, how many Nigerians are in the UK? I'm not sure that anybody can tell us. So, you cannot export talent when you don't even know how many talent you have and you don't have a system. Let's even start from the very, 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 very far big thing. We don't have a census to tell us our population, and then you start walking down from there. So, okay, so what population of that are people who are talents that can be used? What population of that would grow to fill the markets or the space that they would leave, etc. So I guess my rambling around brain drain is to say I think it's demonic to try to ban it. I think people leave because of the context more than anything else. And I think that if we can get some things right, just building on my experience at Nigeria CDC, for example, then people may choose to stay. Yeah. Big may. I'm not saying they will. You can try.
Okay, so I want to finish up on recent breakthroughs in other areas. So, like the new malaria vaccines and then the long acting HIV agents. I mean, HIV is more or less something that we've solved now. So, I think it's called lenacapavir, although we're not having issues, obviously, with the whole USAID funding that has crippled a lot of access to that. But anyway, that's a political problem. But history kind of tells us that, access will always lag dramatically for African populations. And I think maybe just to close off on this, what are the structural or political shifts that are needed to make sure that we are not always at the back of the queue? I know it's a big question. Fundamentally, this comes down to an economic challenge as well. If you don't have money, hide your face, as they say. You cannot really walk to the front of the queue and demand that, somebody should give you vaccine and all that. But do you think health ministries, obviously, should they focus less on donor-driven procurement? If they do that, how are they going to replace that? Or should they fight? Should the health ministry, I don't know, in say Nigeria, for example, should they just fight for a bigger allocation for procurement from the Nigerian government, and how would they be able to make that case if they were to do it, right? If you're the health minister wants to get a bigger budget for health procurement in Nigeria, how would they make that argument? Especially because you're going to take resources away from other parts of the country and other, needy areas as well. How would a public health expert like you weigh the cost benefit of doing this kind of things? You want to take money from somewhere to fund health. Yeah. Sorry, that's a big rambling question, but I think maybe it will help us tie back everything we've talked about together.
Maybe I'll go and first shout, another COVID is coming, oh.
Without concentrate minds, yeah.
Exactly. I think fundamentally, if people don't think they're at risk, it is very hard to see any ownership. It's very hard to answer that. And again, I'm glad I said earlier that I've never been a minister of health because I think especially in a country like Nigeria, it's so hard because, you're dealing with so much that is within your control, but I think you're also dealing with so much that is completely outside of your control. So you can find, people say there's an Abuja declaration and at least 15% of the budget every year should go into health. It has never, it has never happened. I hope it would happen in our lifetimes. But, all you can do is shout and all about that. But I think there are some innovative ways to start thinking about this. I recently heard the coordinating Minister of Health of Nigeria, Minister Pate, talk about, and I am paraphrasing, but hopefully not saying the wrong thing. But he said, how in the US, when you give to charity, you get some form of tax break or tax, I don't know what the official word is, tax relief, I think, for a percentage of charity given in quotes that you give. So a lot of philanthropists and others do it. And so his point was, we have incredible private sector in Nigeria. We have people who are so wealthy that they can afford to fly in most expensive musicians for their children's weddings. And it's almost like, how about we start tapping into some of that, whether it's from the philanthropists or even diaspora Nigerians, in a way that is attractive to them and in a way that benefits the health sector? I feel like we haven't tapped enough into our own resources, especially our private sector resources in Nigeria for public health delivery. I did spend time trying to work on resource mobilization with the private sector in Nigeria. And I remember hearing comments like, are we going to build something and put his name there? If we're not doing that, it'll be hard to convince him, or I'm not going to tell you who him is. But public health is not, we're not talking about building hospitals here. We're talking about how do we strengthen the systems to procure vaccines? How do we strengthen surveillance systems? How do we strengthen the ability to move from testing a case to taking it to an infectious disease center, etc.? Like, there's so much that goes on that isn't seen and isn't a way to put someone's name or brand someone's name. But that said, I think that just tapping into that whole private sector space and making things attractive for them, whether it's through tax relief or I don't know, even when you think about corporate social responsibilities, I feel like people they'd rather go and dance and share Indomie in a place in Lagos or in Abuja as corporate social responsibility than buy vaccines, for example. And it might be that selling or dashing noodles or Indomie, whatever, is more expensive than buying a dose or choosing to sponsor a dose. But the visibility that you get from your company going to dance in the market
the
is
incentives.
way
Yeah.
more. Yeah, the incentives for you are way more. So how do we, as public health professionals, think about making the incentives stronger for philanthropy and private sector? There's all this talks, and I think for you, we've spoken about this, of course, outside of the podcast, where we're talking about sugar tax and sweetened beverages and whether that money can actually go somewhere. Again, I don't understand it enough to say, but I wonder if that could be a potential source for increasing resources that go into procuring vaccines or even broader health system strengthening. I think we really need to move from donor dependence, but also, there can be negotiations. I look forward to who would criticize me for saying this, but I think even in things like Lassa fever research and development, you cannot test the vaccine outside of a place where you have cases, which means that countries like Nigeria, Liberia, Sierra Leone, Guinea will likely be where Lassa fever research will be done, and it's being done. How about those countries start to negotiate now with the developers, with the potential manufacturers, with the people that are funding research and development? So it's not just about, come and work with us to develop a vaccine. It's, if we work with you, what is the guarantee for access to our population? It is, if we're contributing X amounts now because you're going to do this research in sometimes government hospitals and it's government resource. So if we're doing that, what is the price percentage that we would get for offering our facilities? to you now. I think those are negotiations that the government needs to have and needs to start having. It's not, again, a missed opportunity. Oh, yes, come and do a clinical trial in our country, and that's the end. But how about negotiating early on for access so that you get a preferred price, for example? And it's not impossible. Companies want to develop vaccines for different reasons, sometimes for profit, sometimes not for profit, but to sustain the companies or whatever. But also governments need to put something on the table. If you want to keep your company or if you want to get your profit or whatever, this is what we want in return. I don't think we do enough negotiations at the moment, and that's something that needs to come up. And so, it's moving from that donor dependence in terms of, oh, we're begging, just give us, to actually we're working with you, and we're contributing in this way. So in return, this is what we want. So I always dabble between optimism and pessimism when I talk about this whole space, because people have spoken before I was born, people are speaking now, and people will likely continue to speak after I die on how much we need to move from dependency to self-sufficiency and how much our governments need to put. But we need to be more innovative and think of the untapped opportunities, whether it's private sector, whether it's philanthropy, whether it's sugar tax, or whether it's negotiating access during R&D processes. Those are some of my early thoughts.
What I really love about this conversation and your thinking is it's so interdisciplinary, and I can't help but ask, do you think there's a bit of an over-reliance on specialists, especially when it involves the health sector? I'm talking policy now, not actually the technical aspect. I don't know why we had to change the title to Coordinating Minister of Health, but I don't know, whatever. So, for example, if you make an economist your health minister, for example, it would not be so far-fetched for that person to say, okay, I have limited resources. I can take a whole year's budget and just spend on malaria vaccine. Let's see how far that it's limited. It's never gonna go around anyways, but let's prioritize, right? I know people criticize economists a lot for how they think, but I mean, you see things like hospitals. It's a business, even though it's a hospital, but we have doctors running hospitals and they do a very poor job, just like academics running universities. Right. So do you think there's a bit of an over reliance on specialists, working on health policy?
100%. I'm going to start by saying I think we're currently very lucky with our coordinating minister of health because, of course, he's a medical doctor, but he also worked at the World Bank. And so he has a very strong health financing background, is my view. And so I just wanted to add that, but also because I really admire him. But it's interesting because I was speaking to a mentor recently who is a medical doctor himself and a health leader. And he said to me that if you think about the fact that for your average chief medical doctor, he goes to medical school, passes, does his residency, housemanship, all of those things. And then he becomes a doctor, he prescribes medicine, and he becomes, after some years, registrar, consultant. Then he'll start hustling for chief medical director. And then one day you see him shaking hands with the Minister of Health in the Minister's office, collecting his letter, appointing him as chief medical director. This person hasn't had any form of leadership training. In many cases, hasn't had any form of budget or economics training, especially when you look at the Nigerian curriculum. This person hasn't been exposed to problem solving outside of the healthcare setting in many cases. And so the problem he's used to solving is, PCM for a child, how many tablets or how many doses do you give? It's not the problem of how do we subsidize or how do we optimize the resources that we have. So I definitely agree that there is an over-reliance on specialists, especially at the hospital level in Nigeria. And I think the politics is crazy. I think there's a whole thing about, in fact, even for ministers of health, sometimes you see a letter from Association of, and I don't mean this in a demeaning way, but sometimes you see letters from like Association of Nurses or Association of Medical Lab Scientists saying our next minister must be a nurse or must be a med lab scientist. And sometimes when you see that, they're not talking about the capabilities that this person could bring. They're talking about the fact that the association must be represented. We must be put in front. And so I think we need to move from that whole specialist, doctor, whatever view to the interdisciplinary nature. I don't have a medical background. My background is all in public health from bachelor's through to now my doctorate. But sometimes, even in rooms, I get oh, you're not a doctor. And therefore, but this is not about me. And it's really intriguing. It's almost like we put so much focus on the title and less on the capabilities that they bring. So that's one bit on the over specialization. But I also think that we need to see more doctors or better training for doctors, nurses, med labs. Like, it shouldn't all be about the technicalities. We should integrate more leadership, problem solving, economics, other aspects of it, so that the interdisciplinary nature comes from learning, but it also comes from doing. I was just about to say maybe I will become the first minister who's not a doctor, a medical doctor.
I hope so.
Well, I actually do not think that Nigeria has ever had. I'm being careful in choosing my words, and we can verify, but I don't think, at least in my own life, let me say in my lifetime, that Nigeria has had a non-medical doctor minister of health. And for me, it's less about whether the person is a medical doctor or not, but about what expertise and interdisciplinary thinking they bring, because health delivery, healthcare system strengthening, and all of that is not just about the healthcare sector. There's so many dependents and determinants that the health sector relies on. And if the person doesn't understand enough of that, then they're just pouring water in a basket.
Oyeronke Oyebanji, thank you very much. This has been an education. We always tell our guests that because of the nature of these conversations that we have, we'll hopefully, have another conversation in 1 year, 2 years' time, see where things are. Maybe that vaccine manufacturing plant has finally taken off.
Exactly.
Thank you very much. It's been a pleasure.
Thank you guys so much.
Thank you.
You're listening to Frontier Matters, the podcast from 1914 Reader.